everyone. My name's Porchia Dees, and I am a CAB member, a Community Advisory Board member for the Well Project, as well as I am the Linkage to Care Coordinator for the Black AIDS Institute.
I have seen you before there, I think.
Yeah. I've been working in the HIV direct services field and doing advocacy for about 7 years now. And I'm super excited to do this leadership exchange with Dr. Brown. And Dr. Brown, would you like to introduce yourself?
Sure, thanks a lot, Porchia. And I'm excited. I knew I'd seen you before. My name is Gina Brown. I'm a physician. I'm an OBGYN, and I work for Gilead Sciences. I started out doing OB and doing HIV care for women from the beginning of the epidemic. I started out as working with women who were substance using. We had a substance using women's clinic at Harlem Hospital Center that was started by Janet Mitchell, who was very active and energetic, getting people to pay attention to women living with HIV. And it very quickly morphed as the epidemic came along into a women's HIV clinic, and that's how I got started. And I've been working around women's issues with HIV from the beginning of my career on, which was from the beginning of the epidemic on. I came out of residency right around the time that we started, just before we started seeing HIV in women. And so I've been lucky enough, I think, I went and did a fellowship, and the fellowship director was very involved in HIV research, the Women and Infants Transmission Study. And so I used to sub for him in the clinic that he ran, and then I just took over the clinic when I graduated.
Awesome.
And so it's been it's been exciting and interesting and gratifying to see this from the very beginning and kind of what incredible strides we've made. So I worked at NIH for 10 years before coming to Gilead, and was able to work on the issues around research, both in prevention, women and girls issues in particular, and then medical issues related to HIV, and being able to do some really interesting things with bringing folks from the community together to hear from them. So it's been a fun way to see all the different parts of it, in a gratifying way, because I've met these amazing women along the way who have schooled me along the way. And so here I am. I work in HIV prevention at Gilead. I'm a medical scientist.
Yeah, that's one of the reasons why, when they brought this idea of doing a leadership exchange to us, and they shared with us different people who we can interview, so, I looked through all of our WRI members, and our other CAB members, as well as our partners. And when I read your bio, I was like, oh yeah, that's who I want to interview, because of, I was born HIV positive in '86.
Mm-hmm.
And so, being someone who acquired HIV through vertical transmission, and also I'm 34 now, and I feel like I'm getting old, and I have baby fever so bad. And I'm super interested in having a baby, and my baby being born free from HIV. So the fact that you were an OBGYN and worked with women who, gave birth or work with women with HIV, and your background and everything, I was like, yeah, that's what stood out to me. And that's why I wanted to interview you.
It is so exciting for me to continue to meet young women, young men who were born before we kind of figured out this stuff, right, and have done really well, and they're healthy. And it's like an amazing example to folks that, yeah, you can live with this, and also you can have a baby and you can prevent that baby from being a baby born living with HIV. I mean, it's funny because I don't know that everybody appreciates what it was like before, and then just how once it changed, it was like, phew, it was really exciting. And like the knowledge just grew exponentially.
And it's interesting saying, you worked with women with substance abuse issues, because that's exactly what my mom struggled with. And she didn't know she was positive until she had me. And, you know, my aunt and uncle had to take legal guardianship of me because she wasn't in the, you know, proper mindset, or, you know, she wasn't able to give me the care that I needed. So
Uh-huh.
thank God for my aunt and uncle. And I think if my mom wasn't going through what she was going through, that she would still be here today, because I lost her to AIDS related illnesses in 2004.
I'm sorry to hear
But
that.
yeah, no, it's no worries. But yeah, I think that, you know, she would still be here today if she wasn't going through all of that. Can you kind of like share the process of, like, when someone is has HIV and they're pregnant? Um, can you kind of like share the process of what they would have to go through in order to have a baby without HIV?
So back in the beginning, all we had was AZT, which doesn't even get used as a treatment anymore. It was the one drug that was available, and the study showed that if women took AZT while they were pregnant, then it prevented them from transmitting the virus to their infant. It decreased it by 2/3. So of every 100 women, 66 plus did not pass HIV on to their baby.
Okay.
And that was all we had for a long time. And so in the beginning, even before that, people were saying, how can you do this to women? How can you do this to their babies? How can you make them take this terrible medication? And then the data came and it was like, oh. And so for a while we had just that. But we were almost lagging behind in terms of the excitement of treating women for their disease itself. So we got
Right.
more medications, and people were saying, well, you don't want to harm the baby. We don't know anything about this. And for those of us in OB who did this, it was that benefits risk, which is if mom gets sick, that baby is not going to be a healthy baby, or may end up born early, or we don't know what will happen. So there was a lot of struggle to see women as more than just a vessel for having a baby that had to be kept healthy, but we needed to keep them healthy. And
Right.
I
Right.
think when I read one of your questions, it was about sort of this concept of treatment as prevention. That very quickly morphed as we got, like, the medicines ramped up, triple drugs, they called the cocktail, became the norm. And there were a group of folks who really fought hard for how can you take a woman and not have her get, keep her HIV managed, so that you'd only use AZT to treat her. So, because that's what we knew would work for the baby. And so, again, data got collected to realize that triple drugs really did keep mom healthy, but also markedly decreased the rate of HIV transmission in their babies.
Right. And the baby has to take the AZT afterwards too, right?
So that in the beginning, the baby takes AZT for 6 weeks after. And then as we got more medications, there's still groups who take just AZT. There are also groups that will take multiple medications. It all depends. And it's for the 6 weeks afterward to cover what exposures they may have from birth. But the other thing we learned, and I learned it, a patient came in and sat down in my office one day on a Monday and said, hey, listen, I heard on the news that if I have a cesarean section, my baby won't get HIV. And this was before we knew about viral loads and all of
Oh,
that stuff. And
yeah.
so it was when we were first knowing about viral loads, and about if a mom, what they looked at the data, and if mom had a viral load over 1,000, then her risk of passing the virus on to the baby was higher. And if it was less than 1,000, then the risk was very low. So for moms who were not fully suppressed, which was an interesting concept back then, they would get cesarean sections if they wanted. And that would also decrease the risk of the baby getting the virus going through the vagina.
Right. Yeah.
So it's like it's almost like what we're seeing with COVID, where the knowledge is snowballing. Only
Yes.
in those years, it was snowballing over years' time, as opposed to snowballing over weeks to months' time, where we are now. And it really set the basis for a lot of the science that we're doing now around COVID. So it was exciting, because you're like, oh my goodness, we can work with women and they can have an opportunity to have children and live normal lives if we can keep their virus undetectable, which is where we are now. So if mom is undetectable, her risk of passing the virus to the baby is incredibly low. And
Right.
so, and as undetectable used to be less than 200, and then it was less than like 50, and then it was less than 40, and now it's, you can get really low in terms of figuring out what's an undetectable viral load.
Yeah,
So
for that progression.
yeah, yeah. And so for you, as if your viral load is undetectable, meaning you're healthy, you've taken your medication, and you stay on your meds, then your risk of transmitting the virus in childbirth to your baby is virtually non-existent. I mean, it's very, very, very low.
Yeah, I now I know that, and that's kind of why I wanted you to explain that, for others to hear that in this conversation. So thank you for doing that. And then, yeah, what you were referring to in one of my questions that I'm going to skip over now, but yeah, I wanted to also highlight that, the advances in treatment and research, and the fact that U equals U is a fact now. We kind of already like seen that prior to it was to
Mhm.
the fact that it was proven in this whole vertical transmission, or women giving birth to HIV negative babies. We kind of already knew that before U equals U was proven. So yeah, I'm glad that you highlighted that. We were seeing this beforehand. Feel free to also ask me any questions. I have about 4 more questions that I want to ask you, but feel
Okay.
free to also ask me any questions you would like.
You said you just started realizing that, yeah, you could go ahead and have a baby. Did you ever feel like you got pressure to not have a baby before?
So growing up, I had my first sit down where someone told me I had HIV. I was in the 6th grade, and it was
Okay.
my social worker at Children's Hospital Los Angeles. Um, there
How did
were
that go?
Right. So in 86, when I was born, there were no HIV medical specialists in my area. I'm from San Bernardino, California. So I
Uh-huh.
had to be transferred all the way to Children's Hospital. And I mean, it was an awesome hospital. Um, the way that my social worker, uh, she just pretty much sat down and told me I have HIV, which I heard that word before. I heard my doctors and my parents and stuff talking about it. I just didn't know what it was.
Mm-hmm.
And then she told me about, she explained to me what HIV was and told me how it's transmitted. But it was from a very like sex negative approach. And so she didn't directly say, oh, you can't have sex or you can't have babies. But like the way in which she taught it and how it was spread, I assumed like, okay, well, I can't have sex then, or at least not without protection, or I wouldn't be able to have a baby. Like she didn't talk about treatment and how the treatment works. She just talked about how the virus was spread.
That's a lot for a 6th grader.
Yeah.
Jeez.
And even when I learned about it in sex education in middle school, it was the same thing. Like, so I kind of just always went through life feeling like I can't move like everybody else can. So, or I can't do some of the stuff like everybody else could.
Mhm.
But now I know better.
When did that start to change for you?
That started to change when I finally got involved and I started after I transitioned out of pediatric HIV medical care, which was when I was 21, I moved into yeah.
Wow.
I transitioned into adult HIV care, and I kind of fell out of care in that process because it was a lot different. But then
Yeah.
when I finally came back and I started volunteering, I went to AIDS Healthcare Foundation. I started volunteering and I started becoming like a mobilizer, and then I got my first job in the field. And
Awesome.
that's when I started learning about meeting other people, other women who had been living with HIV and who had had babies themselves.
Mhm.
I started learning about everything. So I was older. I was in my 20s, like 23, 24, which is kind of sad, but yeah.
I
I
mean,
mean, it's late.
well, no, but people, that attitude hasn't completely gone away.
Right.
I can remember practicing, and I was getting a call from, there was an adult infectious disease provider, and she called up and started yelling at me because one of my patients was pregnant. And I'm like, I didn't do it, you know, but her attitude was how, almost like a how dare they? And I
Right.
think that has changed a lot among providers. I mean, it's people have, yeah, there's just, I think a lot of that has changed, although probably not completely.
Right,
Um,
right, right.
and it was, yeah, I mean, there was a lot of information, but even the providers didn't seem to always have it, and even some of the HIV providers. And so it's a shame, but quite understandable that you may not have gotten the right information till you were further along. And even
Right.
then, people still have judgment about it. Like if there's any
Exactly.
possibility, you shouldn't be having children, which is wrong.
Exactly.
Yeah.
Um, so how did you get started in your career? Did you always know you wanted to be an OBGYN or, work in do HIV work? Um,
Not at all. In medical school, I thought I was going to be a pediatrician or a pediatric psychiatrist. And then I went to a school that gave you patient interaction from the very beginning. It's called Case Western. And you had a pregnant woman that you followed. They wanted you to learn about primary care. And I love that these people knew their patients from having babies, but they also knew them over the years of their lives as they grow older. And so I like that primary care part of it, but I also like the surgery part of it. And then when you do these rotations where you spend 6 to 8 weeks doing something. So when I did OB, I remember thinking, God, I'm exhausted, but I really love this stuff. So that's how I got there. And this is something I think it's important for people who look like us. I didn't know much about doctors when I was in high school. It's not like I spent much time at them or anything. I went to a summer program between high school and college, and it was for then called minority students. So it was Black and Latin students. It was in New York City. It was called PrEP. And kids who wanted to go to medical school were already admitted to college. And that's how we spent that summer. And in addition to schoolwork, they had Black doctors come and talk to us, Black and Latin doctors come and talk to us. So for me, for the first time, I saw people who looked like me doing something that I thought I wanted to do. So I felt like I had a better sense of what this means in terms of having a life, and that there are people who look like me that can do this. And so I think it's important for all of us, for anything we do for a living, to think about people coming behind us, the next generations of folks, that they need to see people who are outreach workers. They need to see people who are social workers. They need to see doctors. They need to see lawyers who look like them, to know that this is a job you can do. So.
Right. Awesome. And then you kind of mentioned your career path. And so, can you talk a little bit about, how each piece, your OBGYN years, and then your research years at NIH, and then where you are now, how that has influenced the way you approach your work with women in HIV?
Okay. I'm going to take you half a step back, though.
Okay.
So neither of my parents went to college. My mother probably didn't she might have gone through 8th grade. And when I was a kid, she took her GED to get a high school degree. And then there were all these programs opening up because there was a nursing shortage, and she went to nursing school. And I think that had a tremendous influence on me, just in the concept of medicine, but also an influence on me about, you can do whatever you want to do, you can get it done. Because she was 3 kids and a husband, and working and cleaning people's houses to pay for nursing school, and managed to get it done. And I think we as a people need to appreciate what folks have to do to get it done.
Right.
And that sometimes it's not easy, and sometimes it's not lovely laid out. But for me, I always knew I wanted to do work that would take me in a community that was underserved. I took Spanish in college, even though I came out of high school speaking French, so that I knew I wanted to work on the East Coast and the inner city. And at the time, those were the people coming in who may not have had great access to healthcare. And so that sort of, to me, defined the populations I wanted to work with. I never wanted to do a private practice. I was lucky enough by doing the substance abusing women and doing women living with HIV before I started a fellowship that there weren't a lot of people who wanted to do that. And so a lot of the research was being done. So I got to be known as someone working within these research projects and working within policy. I think I really benefited from the fact that not a lot of people wanted to do this, I have to be honest. And it was a group of folks I loved working with. And it always combined, because we do so little, research, policy, and then the clinical part of working with women. And so those combinations of things, that research, policy, and working with women clinically, has been a big part of, working with the New York State Department of Health AIDS Institute to build guidelines around women. Being one of the folks who was picked to do the first set of national guidelines only came around because there weren't a lot of folks doing it, or giving talks at meetings and stuff because there weren't a whole lot of people doing it. And so I think I was fortunate, but it was also something I took on. When my OB training was for high-risk OB, women with medical problems other than just being pregnant, which is not really a medical problem, by the way. And so HIV was very much a part of that. Women who had diagnoses that made them sick. So I did that with, women who had heart disease and women who had kidney disease, but HIV was also part of that. And I was lucky to be able to take over a clinic that was built on a combo of research, money, and social services money, and the clinical part. We used to say we kept it together with paper clips and plastic tape with all these different funding sources. So women were part of research programs, but they also got clinical care, even if they didn't want to be part of a research program. From doing that, I got to serve on a number of NIH committees that determined what research needed to happen, particularly around women. And that's kind of how I got there. They were building a prevention section at microbicide, or for microbicides, looking at prevention that women can use. And I was on a committee that was looking at what's the kind of research that needs to be done. And then they started up this section and they called and said, hey, well, look, we're looking for someone who might be interested in this. If you know anybody, let us know. And I hung up the phone. I'm like, I'm interested. So I talked with someone there, and that's how I ended up there for 10 years. And it was still a combo of figuring out what research needs to be done. So we weren't doing the research. We worked with community members, scientists, community members living with HIV, people who ran programs, clinicians, to come together, kind of like WRI does, to come together and figure out what research needs to be done. For me, it was women, and then in prevention, then ultimately in comorbidities, other illnesses that everybody has. And yeah, and so it was still this policy and research policy and program development and the actual, what are the questions that need to be answered? And then I got to Gilead because it was an opportunity to do some of the clinician education, to get people to do small projects that answer these questions. You were around for Essence Festival, right?
I didn't attend the Essence Festival.
But when it got kind of built, but not built, but sort of that way to bring in this women and HIV issues. Yeah. And so we were able to do that through Gilead, and then through the partnerships with the community folks, with Black AIDS Institute that took a leadership role, Sister Love, that, and you
That's awesome.
make it an opportunity to get to women, women who are living with HIV, women who are not living with HIV, to provide education. And so being able to do that sort of stuff was it sort of all came along the way, which is being able to get to the community, get to providers, get to researchers. It's, for me, it's all sort of the same work, but in different ways.
Yeah. I like how you laid that out, and throughout our conversation, we kind of like talked about how, you know, the education I received from my social worker at Children's Hospital, and then, you know, how providers sometimes still hold these stigmas or biases. And so, yeah, the fact that you are now educating providers is awesome. And then the research part, that kind of like leads into my next question. As you know, we've seen over the years, a lot of the times women aren't included in this research as it pertains to, you know, the treatment and stuff for HIV, PrEP, all that stuff. Do you see research being more inclusive of women living with HIV and verticals? And yeah, I'm saying women, but verticals are definitely not included in this research.
Yeah.
Do you see that being more inclusive now?
I
And
think
especially now, since we have you in the role that you're in now.
I think they're growing. I mean, the efforts are growing more. I mean, you're right. From the longest, you know, women were, if they had the capacity to get pregnant, they were kept out of all research studies, not just HIV. And by capacity, you mean like, you know, from teenage up to 44, we didn't have data. And so there's the Office of Research on Women's Health at NIH put forth something like a booklet like this that talks about making sure, you know, you can't exclude women unless you have a reason, you know, and the reasons are like, I'm doing prostate cancer research, so women don't have prostates, they don't get prostate cancer, it's because it's a men's organ. That would be a reasonable reason. But simply because, oh, she might get pregnant, you've got to be able to handle it. And so that's congressionally, I don't know if the word is mandated, but kind of built into kind of federal funding for research. And then a lot of other places that don't use federal funds are recognizing, implementing that you need to get research done in women if you're going to be, if that's half the population you're going to be treating with something. The folks from the Well Project, Don Averett in particular, and some others were instrumental in getting a study called the GRACE study done. That showed that, you know, if you set it up right, you can get women to enroll. Because the other people used to think, oh, they won't enroll, they've got other stuff to do. Well, if you set it up right, you know, with them involved in how you set it up, it can happen. And it did. And so I think there's a lot, that brought a lot of notice to particularly women living with HIV and how you can have women living with and women at risk to participate in studies. So I think it's coming along. It's sometimes you have to remind folks, and sometimes you have to remind them aggressively.
Right.
And sometimes I think the community has to step up and say, hey, you know, nothing about us without us.
Right.
You know, you can't build a process and build a medicine and do whatever if you're not going to study it in us. And so I think we're getting there.
Yes. That's one of the reasons why I love being a part of the Well Project, because, you know, they do a lot of, you know, with the women's research, the WRI, and just, you know, they do a lot of that work. So I'm super excited about that.
I have to say, one of the things I've loved about being part of the WRI is that it brings such a group of people together from all different backgrounds and all different educations and all different life experiences. And some of the things the clinicians or the researchers may take for granted, the women living with HIV and the women at risk for HIV are like, I'm not interested in that. We did a great session on cure, and there were some women probably in their 40s and 50s who've been living with HIV for a long time. And they're like, so get this straight. I'm on a medication that works, that I'm fine with, and you want me to stop taking it to see if I'm cured?
Right.
You know, so it makes folks think about how you need to involve the people who would benefit or take the risks of something in the conversation.
Right. Yes, That's super important. Thank you for bringing that up.
Have you, when you think about having a child, or just that you're 34 years old, how would you want the information? I mean, you've made an effort to be involved in this. How would you bring that to others coming along? And how would you want the information both gotten or looked for? How would you want that to happen in an ideal world?
Great question. First of all, this might be like just a long shot to like something difficult to ask for, because like we both mentioned, you know, like the stigma and the judgment, like I would want that to be not there. Um, like I would want to feel like, okay, this is something that I can do and that I'm allowed to do. Like as an HIV positive woman, I'm allowed to have sex.
Yeah,
It's my right. It's not, it's a, what is it? It's a basic
human
necessity
need.
like in life. Yes. Like, and then having a baby is like you know, we're supposed to procreate. Like that's a natural thing. Like, and just because I'm positive doesn't mean that I can't do that. And even if, you know, we have all this information now that HIV is, you know, preventable, that a woman can have a baby who comes out HIV negative. But even if I do have a baby and the baby doesn't come out negative, so not so what, but like that's okay too. Like I was born positive. I look at being positive differently than most people because I've had it my whole entire life. And
Mhm.
I turned out fine. Like, yeah, there were things I had to go through and you know that I wouldn't have went through if I wasn't positive, but I think that's life. I think everybody has things that they go through and things that they struggle with, you know, like
Mhm.
I don't trust me, that's the last thing I want to do is have a baby and my baby come out positive. Like that's my biggest like you know, that's the generational curse that I want to break. That's my biggest like hope is to have my baby born free. But I don't want to have to feel that guilt and that shame for if, you know, that doesn't happen. You know, I know the Well Project is doing a lot of research behind breastfeeding
Mhm.
um,
Mhm.
while you're pregnant or HIV positive women in breastfeeding. And so, like, you know, I just want things to be like less judgmental. Like, we're able to breastfeed, we're able to do everything like just like every other woman is supposed to is able, you know, like so I just would want the information to be given in like a less judgmental way, in a more like uh I don't know if sex positive is the right word, but yeah, you know, like from like taking into consideration the wants and the needs of someone who is HIV positive, like, and not
Mhm.
just
Mhm.
saying, oh, okay, you can't breastfeed, you shouldn't be doing this, you should know, like, we can. And, you know, like, I would want um, for different providers that work with, you know, OBGYNs and stuff that work with women who are HIV positive and want to have a baby. Like I would want that information somewhere where it's easily accessible because there's not a lot of OBGYNs that do work with people who are
Mhm.
HIV positive, and then in a who are like, you know, who look like us and who are not judgmental, you know,
Uh-huh.
like so I would want that to be made available. Like, what are good OBGYNs to go to? Like, who won't judge you? Who won't, you know?
Mhm.
Um,
Mhm. It's
uh,
funny because you there are two things that I that stuck with me when you're talking about the issues of stigma. From the side that I work at, we often address stigma as though it's the patient's problem, as though a person is a patient. It's like you come at it with, and you've got to, think better about yourself and whatever, as opposed to recognizing that stigma can be levied upon an individual by their providers potentially too. And so it's got to be a two-way street. I mean, you've got to work with the providers who are judgmental and may not even realize that they are. You know, an expression of your face, a sound of your voice, a way you deliver a message. And the concept of sex positive really strikes home with me working in prevention, because I shouldn't say we always, it is often talked about as though, oh, you've got to keep yourself from getting this disease. And it makes sex like a dangerous and scary thing, as opposed to let's keep you as sexually healthy as possible.
Right.
You know, sexual health and reproductive health, it's a right, it's a way of existing, and not, you've got to avoid that. That's horrible. That's, you know, it's like it's dirty or something that you would catch something from.
Right. You got to understand that you might be talking to people who already have an STD or these things that you're talking to them about, like, and so how would you talk to that person? It's different from, you can't say, oh, you got to avoid it because they already have it, you know, so what do they do now?
And it's not something you've done wrong. It's
exactly.
The other thing that it strikes me when you talk is that, so there's a cohort of women living with HIV who have had children and they've aged up, but there's also a group of women like yourself, and not just women, but their children who are living with HIV. It's called the Pediatric HIV/AIDS Cohort Study, FACS, from NIH. And they're now, when I left NIH, they were putting together a project that let them learn more about the younger women who are of reproductive age, who were born with HIV, and recognizing that they may think entirely differently than their generation of mothers. And they may, the word function is not what I want to say, but behave differently, go through their daily lives differently. And it's important to understand their sexualization, how they grow into it, how they define themselves, how they think about this, because we're not, the women the studies were done with before are like 40s, 50s.
Right.
And this is a whole other group, and the education, the information, the way you function, how you get brought into these discussions, how you bring yourselves to these discussions, not even wait for someone to invite you, but are part of the world that we live in now. And we need to better understand that to do better, like for healthcare. And, you know, when you switched over to adult care, you said you dropped out for a bit. Well, what is that about? And how do we set up systems so that people feel like they can continue? And not how we set up systems, but how do we work with people who need systems so that they're set up appropriately to meet their needs? You know, right. I hope I'm saying it the right way, but.
That's interesting. That's my first time hearing about that cohort. I'm glad that you guys have that, that you guys are working on. We actually had a session that we did for National Women and Girls HIV and AIDS Day, the WELL Project. And it was called As We See It. And it was me and another woman who was born HIV positive who hosted it. And it was a panel of other ladies who were born positive. And we talked about, you know, what you just mentioned, a lot of those things. So yeah, I'm glad you brought that up. That is like, it's definitely, we're long-term survivors, but the way that we view things is different from some of the older women who are in their 40s or 50s. You know, there's a generation gap in and so we discussed that in the meeting, and some of the stuff you just said, we talked about and brought those issues up as well.
One of the, sorry, I don't want to interrupt. Sorry.
Go ahead.
Now, one of the coolest meetings I was at was in Seattle. The Gates Foundation. It was small, and it was, Dawn was there. I'm trying to think if Jenna was there. I can't remember, but they brought in young women, and it was young women from the US and internationally. And, you know, there was a meeting that was set up, and there was like two organizations, part the WELL Project and another organization that put this meeting together. It was a chance, you know, there were the Ambassador Burks was there at the time, and it was just a really interesting opportunity. But at one point, there was a session set up, and the younger women from both the US and internationally got together, and they're like, okay, you guys set this up like this. We don't want this to happen this way. We're going to give you something that we think you need to hear and do. So basically, they took over the meeting and were able, they made sure that their voices were heard. Because, you know, us old heads had set up something that was one way, and they're like, this is not how this ought to function. I'm like, well, and it was amazing and excellent. They, during lunchtime, they sorted out how they wanted it delivered and dealt with. It was amazing. It was very, very good.
Awesome. That's the perfect segue into the last question. So, you know, you were treating women living with HIV before ART, and, you know, the 076 study that, you know, proved U equals U. Can you describe the shift that you saw in women when you were able to counsel them about this life-changing treatment? And, you know, is there a difference in how you know, would counsel women now who's interested in having a baby as opposed to before ART?
Yeah, it was like, how do I describe it? There was almost like there was shame to being pregnant before, in this sort of, how could you do this kind of way that they were getting from, you know, other people who knew they were living with HIV, other clinicians, you know, people, you know, suppose you're going to your substance abuse treatment or management center, and you are pregnant. They know you have HIV, and there was judgment, and it was almost like people were embarrassed to be pregnant. And once they knew they could do this, as in have a baby, and the baby could live without HIV, or if a baby was born living with HIV, there was guilt and embarrassment that went with it, like tremendous guilt. And to see that start to come away as women began to better understand, whether they got the information from their clinicians or got it out in the world, because word spread pretty quickly. You know, you'd have women say, I want a C-section, da 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 da, and you're like, well, you don't really need one because your viral load is undetectable. And you'd have to explain it, and they're like, oh, okay. You know, so there was a sense of like, that you could own this and you could find joy in it for many of the women. It wasn't a fearful time as much with this, you've got to be afraid, and is my baby okay? And, you know, 6 weeks later, is my baby okay, kind of thing. So it was really, or 3 months. There were, at the beginning, it took 3 months, and they recommended up to 6 months to figure out if the baby was really not born with HIV or didn't acquire it at birth. And just to see that the guilt start to strip away, and also a bit of defiance when someone was trying to lay the guilt on women.
Right.
They're like, no. I know if I do this, this, and this, I can have a baby without HIV. So you need to take a step back and not tell me what to do. Yeah. So that was like exciting, awesome, almost like you'd have to look back at it and go, yeah, this is what was happening. So it was really kind of cool.
It's funny that you say that, because that, you know, sharing a little bit more about my story, I know that guilt weighed heavy on my biological mom, and she kind of even spiraled into a more like bad place after she had me. And then just the judgment she got from my family, like my grandma and everyone, like, you know, like it made her addiction even worse. And so, you know, I'm super glad that I got to interview you today.
Oh, it's so great to meet you.
And that you highlighted all these things. Like, that's kind of why I chose you, because I wanted this conversation to be had for that reason. Because I think still, even today, like, it's like you said, it's, you know, it's not as bad as it was, but I still think that, you know, people still hold these judgments and these biases and stuff. So this was a very important conversation that needed to be had. And thank you for sharing everything you shared. And I don't know, do you have any final thoughts or anything, any last things you want to say to the people?
To the people. One, you're amazing and thoughtful, and thank you. And the questions you put together are, yeah, exactly what we need to think about and be willing to talk about. We're in a really different place than we were at the beginning of the epidemic, and we have to be happy about that. You know, we are, I mean, I would not degrade it and say that it's as simple as, oh, it's like having diabetes. No, I mean, it's an issue, but it's an issue that you can manage. And I think we have to respect that people living with HIV, they can manage it with the choices they make, and we have to let them make the choices.
Right.
Not let them. We have to recognize that they have the right to make the choices. You know, you have the right to have a child. You have a right to take medicine. You have a right to make a decision about how you want to manage this. And it's not my job to tell you how to manage it. It's my job to give you information that lets you make the best decisions possible. And that we have to recognize that women have choices and get to make those choices, that we aren't here to make choices for women, that women get to make the choices they want to make about being healthy, whether it's prevention, whether it's, and it shouldn't just, not just women, but women and young men as well, or, you know, women and men. And young men, people need to have these conversations with them as they're living with HIV as well. But yeah, it's not my job to tell you how to do something. It's my job to make sure you have the information to make a decision. Right.
Well, thank you so much, Miss Gina Brown, for
the
opportunity. And yeah, that's it. I don't, unless you have any more questions for me, I don't have, we can wrap it up.
I'm excited to have had the chance to actually meet and talk with you.
Me too.
And just, I mean, you're thoughtful, and just keep being this thoughtful and keep spreading information to the folks that you get to work with as well, to the next generations of people coming along.
Thank you. All right.
You're not old, by the way.
I feel like it. Thank you.
Thank you.
Okay. Bye, guys.